So our rounding out the first part of our session before the break, we're very pleased to have Suman Srinivasa, who is a professor at again at Harvard MGH and in the division of endocrinology. And we've asked her to sort of give us an update on these new GLP-1 agonists, and we know of them. We see the commercials on television until we want to turn off the television. But at least now we'll hear from somebody other than a person singing a jingle. Suman, we welcome you, and the floor is yours. We'll need you to, yes, share. Perfect.
Great, thank you. All right, well, thank you so much. I'm really delighted to be here today to highlight these medications, the GLP-1 receptor agonists, which have shown some promise in numerous healthcare applications and may have some relevance to our population with HIV. Our learning objectives for today's talk are provided here, which you may be familiar with. And so we'll really address those learning objectives today as follows. We'll first set the background by reviewing weight gain among persons with HIV. Next, we'll highlight the therapeutic potential of these medications in diabetes and weight loss, focusing really on what's known in the general population. We'll then further discuss the importance of body composition in weight loss, and after which we'll review the current studies of what's known of these medications in HIV. And finally, we'll touch upon off-target benefits of these medications. So a lot here to learn. Let's start off, as I mentioned, by setting the background. So weight gain and obesity has been increasing in prevalence among persons with HIV. It has generally been shown that weight gain is associated with ART initiation and generally does not improve with switching ART regimens. Large cohort studies have really allowed us to gain further insight into this. The NA Accord study demonstrated that after 3 years of ART, almost 1/5 of those who were normal weight transitioned into becoming overweight, and 1/5 of those who were overweight transitioned into becoming obese. So the ADVANCE study demonstrated that ART-treated individuals, women with HIV, actually tended to gain more weight than men with HIV, really pointing to some sex-specific differences. And a pooled analysis of a few randomized controlled trials of treatment-naive individuals initiating ART, data of which is shown here in the graphs, reported a higher weight gain in those receiving INSTI or TAF-containing regimens compared to those receiving TDF, abacavir, or zidovudine. Of these INSTIs, dolutegravir and bictegravir appear to be the most consistently implicated with weight gain. And studies have shown, just to point out, additional risk factors associated with weight gain include a low CD4 count, high viral load, and black race. So there are serious consequences for weight gain among persons with HIV. In this recent study of participants on various ART, there was a mean weight gain of 3.6 kilograms over 48 weeks. And among those who gained greater than 10% of their weight gain, as shown here on the right, there was a 2-fold increased risk of developing diabetes and metabolic syndrome, and a 1.5-fold increase in the risk of a cardiometabolic event. And complementary to this, participants who lost more than 5% of their baseline weight had a lower risk of incident metabolic syndrome, really pointing to the impact of weight loss. So while lifestyle intervention should always be advised for our patients, there has been limited efficacy for lifestyle modification towards significant weight loss in HIV. In this regard, really other therapeutic strategies are needed. So glucagon-like peptide 1, or GLP-1, is an incretin peptide hormone secreted from the small intestine following food ingestion, and GLP-1 receptor agonists, or GLP-1RAs, are a class of medication that mimic this physiologic GLP-1 and act on receptors in the pancreas in a glucose-dependent fashion to stimulate insulin secretion and inhibit glucagon release, both effectively contributing to its glucose-lowering effects. And due to these mechanisms, the GLP-1RAs were leveraged for the treatment of diabetes. And studies conducted for diabetes showed additional benefit of weight loss. And then these medications were more directly assessed for their potential as an obesity medication. GLP-1RAs also act on the brain to suppress appetite and the gut to slow gastric emptying, thereby leading to increased satiety, mechanisms of which may account for their utility in obesity. So these medications act on many other systems. In the heart, they've been shown to provide cardioprotection and improve endothelial function. In the muscle, they increase glucose uptake. They act in the kidney to increase diuresis and natriuresis. They also act in the fat to decrease lipogenesis and increase lipolysis. And in the liver, they've been shown also to decrease liver fat. So taken together, there may be a wide range of benefits to these medications, which are still really being investigated further. So listed here are the many GLP-1RAs that are FDA approved and can be prescribed. You may be familiar with semaglutide, liraglutide, and dulaglutide. The majority of these medications are given in the subcutaneous form. The exception of this is semaglutide, in which there's an oral formulation, but it is only utilized for an indication of diabetes at this time. These are given either once daily or once weekly. The medications need to be slowly titrated to achieve maximum dosing due to their gastrointestinal side effects. And of note, subcutaneous semaglutide and liraglutide are the only GLP-1RAs that are prescribed for weight loss, as shown here in yellow. Semaglutide and liraglutide are each respectively marketed under different names, depending on the indication for weight loss or diabetes. And though the active ingredient remains the same, you'll need to prescribe them according to their indication. They are also given at higher doses for weight loss. So this chart shows the efficacy of these medications on A1C and the benefits specific to those with diabetes. On average, there's about a 1 to 1.5% reduction in A1C and possibly up to 2 points with semaglutide. Based on concerns about cardiovascular safety of diabetes medications in general in the past, and more specifically, I'm alluding to rosiglitazone, the FDA now requires actually large cardiovascular outcome trials for all new diabetes therapies. So as such, we have data related to this on these medications. And rather than causing a concern, the majority of these medications actually unexpectedly showed a benefit to CV mortality among those with existing or high-risk CVD in this diabetes population. So this is an important nuance that we do not yet understand the CVD mortality benefit in lower risk populations or those without known cardiovascular disease. But there does appear to be an advantage to patients who have a known history. Semaglutide, liraglutide, and dulaglutide have also shown additional nephropathy benefit, which is quite nice. So what about the efficacy of these different GLP-1RAs on weight loss in those with no known diabetes? The STEP 8 trial helped answer these questions by comparing semaglutide and liraglutide, which are the only two GLP-1RAs approved for weight loss. And they studied overweight and obese individuals compared to placebo, and the largest mean weight change occurred in the semaglutide group, providing almost 2 to 2.5 times more weight loss at 16% compared to 6% in terms of a reduction comparing semaglutide versus liraglutide. And this translated to an absolute mean change of body weight of 15 versus 7 kilograms, so quite a bit. In this regard, we really think of semaglutide as the more potent GLP-1RA for weight loss. We see here that there were overall larger proportions of individuals achieving greater than 10, 15, and 20% weight loss with the semaglutide compared to the liraglutide. So as previously mentioned, there was an unexpected reduction in CV mortality in the GLP-1RAs in the diabetes population. So this then prompted the conduct of such studies to be performed in obesity as well. And the SELECT trial helped us answer this question by assessing CV outcomes in obesity among those with a BMI greater than or equal to 27 with pre-existing cardiovascular disease again and no known diabetes. Patients were randomized to semaglutide subcutaneous versus placebo, And the mean duration of exposure in the study was about 3 years. The primary endpoint was a composite of death from CV causes, non-fatal MI, and non-fatal stroke. And the results showed an overall 20% CV risk reduction with the use of semaglutide. So this is quite impressive that you have a medication here with dual benefits on weight and CV protection, even in the absence of diabetes. And this again is among those without known, with known CVD. We do not yet know how these data extend to individuals without known heart disease, but really this could have far-reaching implications to the HIV population, who we know to have a twofold increased risk of heart disease. So given these data, the current indications for GLP-1RAs were derived. It's important to note these indicate that these medications are not used for type 1 diabetes. In type 1 diabetes, the underlying pathology is insulin deficiency versus insulin resistance, as in type 2 diabetes. And part of the mechanism of action of these medications really relies on insulin secretion, and this is impaired in type 1 diabetes. So when used for type 2 diabetes, this class of medication ideally should be given to those with established atherosclerotic CVD or ASCVD or kidney disease, regardless of A1C. And for those without established ASCVD or kidney disease, they can be used when the A1C is greater than 9, or when the A1C is less than 9, but when weight gain is a concern in these patients. In obesity, the medication can be used if the BMI is greater than 30, or if the BMI is greater than 27 with a weight-related comorbidity. And really, these patients need to have demonstrated a failure of comprehensive lifestyle prior to initiation of these medications. And studies specific to HIV will really help inform us whether these indications should be modified and tailored specifically to our population. So as mentioned, the oral preparation of semaglutide is the only FDA-approved was only FDA approved for diabetes and up to a dose of 14 milligrams. It is not indicated for obesity. However, the OASIS trial went on to evaluate the oral preparation for weight loss and at much higher doses. So they included individuals with a BMI greater than 30 or a BMI greater than 27 with a weight-related complication. Those with diabetes were excluded again, and they were randomized to oral semaglutide 50 milligrams versus placebo. And the results showed a mean weight reduction of 15% versus 2% in the semaglutide PO versus placebo groups, which is really on par with the reduction seen with the subcutaneous formulation as well, keeping in mind that this was a much higher dose of the oral form. The oral version was limited here, it looks like, by gastrointestinal side effects, with a majority of participants reporting these symptoms. And in an exploratory analysis, there was also a higher reduction in hsCRP, which is really quite interesting, 57 versus 14% in the semaglutide versus placebo groups. And while any anti-inflammatory potential of GLP-1RAs are really yet to be elucidated, this could be, this would certainly add to its broad potential as we've been talking about. As of now, semaglutide 50 milligrams oral is still under investigation, but it could be considered a future alternative to sub-Q injections. So really stay tuned as we learn more about this. All right, so potential side effects to be aware of include injection site reactions with the subcutaneous form. These are anti-hyperglycemic medications. However, the risk of hypoglycemia is generally low and may be more likely to occur when used in combination with other diabetes medications, such as sulfonylureas, insulin, and the glanides. Unfortunately, gastrointestinal symptoms really preclude many patients from being able to take these medications. It has been reported sometimes in up to half of patients in the studies. As highlighted before, a slow titration of the medication is useful, as symptoms may subside with tolerance of the medication. Pancreatitis can occur, and we generally do not use it in those with a prior history of pancreatitis. They can also lead to biliary disease, and acute renal insufficiency has been reported, but is quite rare and may be really compounded more so in the setting of the GI side effects and dehydration and hypovolemia. There is a black box warning to be aware of with regards to a personal or family history of medullary thyroid cancer, and that's really been driven mostly by data found in rodent studies. Just speaking of malignancy, there have been some concerns raised over potential malignancy risk extending beyond medullary thyroid cancer. However, really several meta-analyses indicated that GLP-1 RAs do not increase malignancy risk. And the STEP 3 and 4 trials went on to report that the incidence of malignancy was 1.1 versus 0.4 among semaglutide versus placebo groups. And an additional study went on to mine the FDA AE reporting database. And while there were some signals detected with certain tumors as listed here, the study similarly corroborated that GLP-1 RAs really do not cause a disproportionate increase in tumor cases, which is reassuring. So GLP-1 RA combination medications are rapidly evolving as well. And you've probably heard of these, and though not the focus today, it is good to develop more familiarity with them. And really by combining the action profiles of multiple gastrointestinal hormones, this is thought to have synergistic metabolic effects. There's some level of complexity to combining all of these hormones as their actions may not all be in the same direction. So two additional hormones of interest really right now are glucose-dependent insulinotropic polypeptide, or GIP, and glucagon. So on the chart to the right here, you'll see that GIP, similar to GLP-1, increases insulin secretion, but differs in its actions on appetite suppression and gastric emptying. And even so, the combination of the GLP-1 GIP receptor agonists are really thought to be beneficial. And tirzepatide in this class was recently approved for type 2 diabetes, and that was initially, but not too long ago, just a month ago, there was approval for its use in obesity as well. And these medications have shown really a more robust effect on A1C and weight loss. Glucagon, as shown here on the right, also has similar properties to GLP-1 in that it will contribute to appetite suppression, slow gastric emptying, and stimulate insulin secretion. In addition, there may be contributions to other things like lipolysis, increasing energy expenditure, and activating the GLP-1 receptor. And all of these together can provide metabolic production. And these actions likely override the more commonly known action of glucagon, which would be to actually increase glucose production. So retatrutide is a triple action agonist taking advantage of all three of these, GLP-1, GIP, and glucagon. And these agents have been shown a reduction in A1C of about 2% and a mean weight loss of about 17 kilograms. So really more to come on these medications. So with weight gain, we must understand different fat depots. Subcutaneous adipose tissue, or SAT, is thought of as the pinchable fat on the surface. Some subcutaneous fat is healthy and necessary for the essential role of storing triglycerides, but this is an important point that either having too little SAT or too much SAT can lead to metabolic consequences. And when either of these situations present, it could be that the triglycerides then overflow into the visceral adipose tissue, or VAT depot. And VAT accumulates in and around the abdomen and viscera. It's highly inflamed and leads to metabolic complications. So in HIV-associated lipodystrophy, we may see a low SAT, high VAT phenotype. And the ideal strategy for this patient would be to reduce VAT while preserving SAT, as you do not want to reduce the SAT any further. Tesamorelin is an FDA-approved medication for HIV-associated lipodystrophy. It preferentially reduces VAT and preserves SAT as desired here. Whereas in obesity, you may see a high SAT, high VAT phenotype. The ideal strategy in obesity would be to reduce VAT and SAT, however. And so in this regard, the GLP-1 RAs may be effective as a target reduction in both depots. So with regards to weight loss derived from these medications, it's further important to understand how different components of body composition are being affected, namely fat versus lean mass. And with the use of contemporary ART, the HIV population is aging and the prevalence of frailty is really increasing. And we think of sarcopenia in these individuals as well. So in this way, the ideal clinical strategy in HIV would be to preserve lean body mass. In the step 1 trial of semaglutide versus placebo, an exploratory analysis showed that semaglutide reduced total fat mass by 19%, regional fat by about 27%, and total lean mass by about 10%. However, they noted that the proportion of total lean mass relative to total body mass actually increased by 3 percentage points. So moreover, what they saw really was that there was increasing improvement of the lean to fat mass ratio with increasing weight loss, thus suggesting that while there was a decrease in lean mass, it was proportionately lower than the loss of fat. So now let's begin to focus on what's known about GLP-1 RAs and HIV. This was a retrospective study recently presented by Nguyen et al. At ID Week, assessing the impact of GLP-1 initiation on weight, BMI, and A1C. This was a large study of about over 200 individuals. Multiple preparations of the GLP-1 RAs were included. The majority were on semaglutide, and the mean duration of use was about 15 months. Baseline characteristics are shown here. They were on various ART regimens, the majority on INSTIs, and there was also increased metabolic comorbidities as shown on the right, with over half of the patients having diabetes, hypertension, or dyslipidemia. The mean weight reduction on follow-up was about 5.4 kilograms. The mean BMI reduction was about 2 points, and the A1C fell mildly. And while we saw some benefit, I really think the full potential of the medicine wasn't reflected necessarily in this data, as only 41% of those who were studied achieved the maximum dosing. Further analysis showed about a quarter of patients have more than 5% weight loss. About a fifth of these patients transitioned from the obese to the overweight category, and factors that they saw associated with weight gain included a higher baseline BMI and a longer duration of treatment. And they did see that dulaglutide was associated with a decreased odds of having a greater than 5% weight loss. And this is no different from what we've seen in prior studies assessing the efficacy of different GLP-1 RAs. So this retrospective study was recently presented at IAS 2023 by Lloyd et al., in which they assessed the impact of GLP-1 RAs on metabolic outcomes in persons with diabetes and HIV compared to those with diabetes alone. There were about 45 individuals in this group. They showed that persons with HIV and diabetes had significantly greater weight loss compared to persons with diabetes alone. The mean weight reduction was 10 kilograms in those with diabetes and HIV compared to 2 kilograms in those with diabetes alone. And this translated to about a mean reduction of 8 versus minus 1.5%, respectively. There was also a trend towards a greater reduction in A1C among those with diabetes and HIV, though this tended not to be significant. And these data begin to suggest to us increased efficacy in HIV, but this really needs to be investigated further in prospective studies. So Grace McConsey recently shared her results at ID Week 2023 from the first GLP-1 RA study in HIV conducted as a randomized controlled trial, placebo-controlled, and it was really quite exciting to see the results. The study included persons with HIV who were overweight and had increased waist circumference. They were selecting for those with a lipohypertrophy phenotype among those with obesity. These individuals received subcutaneous semaglutide versus placebo at a full dose for 24 weeks. Their primary endpoint was to evaluate changes in VAT using CT, and other endpoints included various measures of body composition. And so we can see here that there was a weight reduction of 8% versus a 0.2% increase in placebo with semaglutide in the leftmost graph, and about 65% of individuals on semaglutide achieved a greater than 5% weight loss. And in the middle graph here, we see that in the semaglutide group, there was a 13% reduction in VAT versus a 5% increase in placebo. And for comparison, this amount of VAT reduction is really similar to cisamarelin. And on the right here, we see that among the semaglutide group, there was a 13% reduction in SAT and a 1.5% increase in the placebo group. So these data really highlight that weight loss with semaglutide is being driven by both SAT and VAT reduction. The study went on to look at changes in fat and lean mass, and there were both fat and lean mass losses in the semaglutide group, though for every 1% of lean mass reduction, the semaglutide group lost 2.4% fat mass. So again, we see that there may have been an overall net benefit to fat loss while sustaining some lean mass loss. And with regards to other ectopic fat depots, there was no improvement in pericardial or lipid fat or liver fat. And overall, there was excellent adherence to the medication. Study-related AEs were similar between both groups. Another ongoing study called the SWIFT study will provide more insight. In this study, patients will be randomized to semaglutide with lifestyle or lifestyle alone in an open label design. And aside from body weight, they'll look at other interesting measures such as inflammation, immune function, and the gut microbiome, which will be quite interesting to see. So this brings us to our pretest question number 1. GLP-1 receptor agonists affect body composition by, the correct answer is C, reducing visceral fat, reducing subcutaneous fat, and reducing lean body mass. Both studies of HIV and non-HIV, as we have reviewed, have shown that weight loss from these medications result in reductions in all 3 depots. And though the studies seem to point to relatively more fat versus lean mass loss, it is still critical to understand how the different components of body composition may be affected by these medications, because preservation of the SAT or subcutaneous fat or the lean mass may be ideal in some clinical phenotypes as we reviewed, such as lipoatrophy and frailty, in contrast to those with diabetes. So GLP-1 RAs are not expected to pose any significant drug interactions via their metabolism. They're degraded by endopeptidases. As part of their mechanism, they are known to inhibit gastric acid secretion by about 20% and delay gastric emptying by about 25 minutes. So 2 potential ARTs of note are atazanavir and oral ripivirine, as they may be affected by elevated gastric pH. These changes in gastric pH, or these changes in gastric acid secretion and emptying are relatively small though, and therefore GLP-1 RAs are really thought to have minimal effect on these medications. In any case, you may want to advise that your GLP-1 RAs are taken 4 hours before these 2 medications in particular. So we've discussed the benefits of GLP-1 for diabetes, weight loss, and even cardiovascular disease. Well, there may be even further benefits that have clinical relevance to other key non-communicable diseases that are rising in prevalence. Indeed, we know that persons with HIV are at risk for fatty liver disease, which can progress to non-alcoholic steatohepatitis or NASH, which can then result in liver fibrosis. So this RCT evaluated participants with a BMI greater than 25, with no history of diabetes and biopsy-confirmed NASH. They were randomized to semaglutide versus placebo. And what they saw was that semaglutide really resulted in a significantly higher percentage of individuals with resolution of NASH versus the placebo group. And they were 7 times more likely to have resolution of NASH without any worsening of liver fibrosis, which is very interesting. So obesity has been linked to the development of heart failure with preserved ejection fraction, or HFpEF. And this is also rising in prevalence with myocardial dysfunction in HIV, which may lead to HFpEF. The STEP HFpEF trial enrolled those individuals with obesity and known HFpEF and randomized them to semaglutide versus placebo. Semaglutide here led to larger reductions in symptoms and physical limitations, as shown by a change in the Kansas City cardiomyopathy questionnaire And there were greater improvements in exercise function as shown here by the 6-minute walk test. And as would be expected, there was greater weight loss. However, the study was not powered to evaluate clinical events such as hospitalization from heart failure. And really further studies are needed to understand its full potential in myocardial dysfunction and HFpEF. There may also be a role for GLP-1RAs in addictive disorders. Although known as a gut hormone, GLP-1 is also produced in the brainstem and is released as a neurotransmitter. There are receptors for GLP-1 in the regions of the brain that are involved in reward and addiction, and this may in fact modulate dopamine. So preclinical research has identified potent reductions in substance use and attenuation of drug-seeking behaviors with several different GLP-1RAs, and this has mainly been seen in rodent models. You can see here that the data has shown that GLP-1RAs suppress motivation to consume alcohol, alcohol-seeking behaviors, relapse drinking, and withdrawal symptoms, may suppress nicotine intake and reward, decrease opioid seeking and withdrawal symptoms, decrease cocaine and amphetamine reward, and decrease cocaine intake. Now, these are really preliminary studies. There aren't really many clinical studies that have been performed. There's one study that showed that was done in alcohol use disorder, which suggested that these medications reduce alcohol consumption in a cohort with obesity. But rigorous studies are really needed to test these medications. And with that, we'll end on our pre-test question 2. GLP-1 receptor agonists have shown several potential off-target effects. Which of the following has been demonstrated in randomized controlled trials? So here the correct answer is A. As we reviewed, the SELECT trial evaluated cardiovascular outcomes among those with obesity without diabetes and demonstrated a 20% risk reduction in the semaglutide versus placebo evaluation. The SELECT trial enrolled only those with pre-existing cardiovascular disease. And again, we don't know the benefit to those without known cardiovascular disease at this time. But we will hopefully learn more with upcoming studies. The STEP-HFpEF trial was not powered to assess heart failure events, as we just reviewed, and preclinical studies have investigated GLP-1RAs to reduce addiction disorders and have shown preliminary benefits, but really we need human studies to thoroughly investigate these medications. And with that, I would like to take any questions at this time.
Fabulous review, Suman, really just great, especially for those of us who are not endocrinologists and but yet we see a lot of these issues with obesity and metabolic disorders. Thank you. I just want to start with a question about the tirzepatide. That's the one that just recently got approved for weight loss as opposed to diabetes only. It had, if I saw correctly, a 16 to 24 kilogram, not pound, reduction in weight, which is just striking. How do you choose when to use that drug versus just semaglutide?
Right, great question. So that is actually just hot off the press with that tirzepatide, the dual agonist medication, in which there was a more potent weight reduction and A1C reduction. So really, if I'm speaking like retrospectively, we didn't really have that in our sort of artillery to use to prescribe to patients. And we were limited to the GLP-1s. And with regards to weight loss, the menu, which you would have looked at, you would have been able to prescribe either semaglutide or liraglutide. And if I were to choose between those two, I would really, we all see the data and see that semaglutide has a more potent weight loss effect. So that really becomes one of the first line in the GLP-1s. And if, for some reason, it's not available, or, oftentimes patients are limited by what's available on their drug formulary as well through their insurance, which has been, quite a problem with getting these medications for our patients who really need them. Then liraglutide is, an alternative to that. Now with this new medication that has come across with more potent weight reduction, I think you're going to see sort of a transition in patients really moving towards this medication. But the one caveat here is that we don't know enough about these new dual agonists yet. I presented data today on sort of the benefits to the GLP-1s. We see that there's great cardiovascular mortality that has been shown in the diabetes population, in the obesity and diabetes population. In the diabetes population, we know there's also a nephropathy benefit. I mean, I think there will be studies that'll start to elucidate that in obesity as well. So in thinking about tirzepatide, we don't understand sort of the full benefit. I anticipate there will be a benefit, but we don't know that just yet. So perhaps, if I'm thinking about our population who are at risk, higher risk for heart disease, and I don't know the CV benefit yet, I may still choose to use a GLP-1. However, that'll be taken into consideration with, side effects and how patients are able to tolerate the medication. That has also limited their use as well.
Right. And I think you just answered one of the questions that came in, just talking about the distinction between semaglutide and liraglutide. And the semaglutide is a little bit more potent as far as weight loss, right?
Yeah. The other thing I want to point out about that, and it was in the chart and we didn't go through all the nuances, is that semaglutide is a once weekly injection. However, liraglutide is a daily injection. So that might also, in your discussions with your patient, may affect what you're going to prescribe. But if thinking about potency, semaglutide, and then also taking into consideration what's available to the patient.
Right. Dr. Mazur, any questions or comments?
No, it's impressive how many different options we're getting now to reduce risk for various comorbidities or complications of HIV. One of the things you mentioned in terms of a complication, you mentioned diarrhea, you mentioned pancreatitis. How important is a 10% loss in lean body mass? Is that functionally important?
Yeah, so that's such a important question. I don't think we know the full repercussions of, the lean mass loss in these patients. And while, there is the idea that there is a 10% lean mass, I think the important sort of nuance that came out of this is in proportion to your body weight, you're actually increasing the amount of lean body mass. It's a subtle nuance. So because, there's such a shift in all the body composition, having an absolute, change in 10%, that may not be the whole story because there's a relative increase perhaps in whole body proportion. And I think we need studies that are ongoing right now to help us elucidate that, but something we should definitely be mindful of in our population that's aging.
Yeah. And what are the most serious adverse effects? I mean, you mentioned pancreatitis. Are any of these complications life-threatening or require hospitalization, or are they just annoying?
Yeah, so pancreatitis, great. So, these can be severe in nature. I think we tend not to offer these medications to patients that have a prior history of pancreatitis because we don't want to, exacerbate a future episode. Now, there's newer studies actually that are coming out suggesting that there shouldn't be such a contraindication, that there may be in fact benefit and we don't actually see increased episodes of pancreatitis. But, you can, if someone has recurrent pancreatitis, they've already had so much damage to their pancreas that, any additional insult can be quite harmful and, can also predispose them to the development of diabetes down the line.
Great,
So
thanks.
there's a couple, I'll call it landmines in the way of trying to navigate access to these drugs, one of which is this one question says that New York Medicaid doesn't cover some of them, covers others. We've been seeing short supply, manufacturing is not keeping up with demand. How are you navigating, especially the negotiating what formulary drug is on which insurance plan, et cetera?
Yeah, it's been extremely difficult. I mean, this is a challenge we've been facing, not just, it's been a while now in which there's been such a shortage and patients haven't been able to get their medication on it. I think with trying to get the medication approved, I think stating the nature of why the patient needs it, they really need to meet the indications for the medicine. And I go on to write a letter, really pointing to, the benefit that may occur for this patient if they have a higher risk of cardiovascular disease and other comorbidities, to really show that they need this medication. But again, even if the insurance company improves it, really we're limited by the supply, and that really needs to increase. Now that may be one advantage to these other, dual agonists and triple sort of agonists coming out, is that when we have more variety to choose from, that will increase supply as well, which will be an advantage, I think. But yeah, I think, I think with the Medicare, Medicaid, that hopefully will change also. That is quite the struggle, because they don't allow for weight loss therapies.
Yeah. And that's been the history with most new drugs that come out a little bit expensive, and over time the prices get lowered, and or at least the access gets easier. Somebody who's had bariatric surgery, but let's see, either a sleeve or has actually had a stomach reduction procedure. The slowness of gastric emptying, is there any particular concerns you have about using any of these GLP-1s in that setting?
Great question. Thank you so much. There have been some studies actually evaluating GLP-1s following bariatric surgery, because it's thought that perhaps this can help maintain weight loss following bariatric surgery. So following bypass surgery, there is some issue there. It's very mild, but there are some issues with weight gain if individuals can't necessarily maintain the lifestyle that is needed after bypass in terms of, the caloric intake and such, and other lifestyle changes. So these GLP-1s have been studied to help maintain weight. And I think they've generally been shown to be tolerated and actually be effective for maintaining weight, which has been really great.
Okay. I guess the last question here, and then I may ask you, if you don't mind, just to type in answers for the remaining couple of questions. But this is a pretty insightful question about that the GLP-1 agonists suppress appetite and also potentially abuse potential. Some essentially mediated process that might be done through dopamine. Is there a concern that this might lead to anhedonia or depression? I didn't see depression as a common side effect.
Yeah. So I think this is a great point. There's a lot of, studies that, need to be done to understand these medications. But actually, so there's more preclinical data, I will say, on this. And actually the GLP-1s, there's a body of literature that actually shows that they may improve depression and psychiatric disorders, and actually improve cognitive disorders. And that is, again, speaking to the broad potential. But I will say that's juxtaposed against, there is an ongoing investigation evaluating these medications and their associated suicide risk, because this was brought up through the Icelandic Medicines Agency, that they saw a large number of cases of suicide. I think they had over 100 cases, and the EMA started investigating whether suicide is a potential risk of medications. They reported some preliminary findings just last month in November. They didn't see a causal association, but they will release another report in April 2024 speaking to this. So hopefully we'll learn more about this, because we'll need to counsel our patients if so.
Well, thank you again so much. It almost feels like I want to ask, will it cure your asthma too? But we'll just suffice with what it's already been shown to do. Suman, great presentation, really dynamic review of a emerging game-changing therapy for folks. And we're very grateful for your time and appreciate your getting to the last couple of questions with typed answers. We have about 13 minutes of break, and then we'll come back, and Dr. Mazur will lead the second half of our webinar, and we'll now just sort of sign off for about another 12.45 minutes.
Yeah, we'll look forward to everybody being back on time.